Good evening, and welcome to tonight's clinical seminar on the myth of misbehavior. For those of you who are new to the Children's Mental Health Resource Center, my name is Elizabeth Errico. I am the Executive Director of CMHRC, and our mission is to provide guidance and resources for the identification and management of mood disorders and bipolar disorder and its newly identified phenotype, dubbed FOH, but also referred to as thermoregulatory sleep dysregulation disorder. We are a 501c3 nonprofit, and so in order to fulfill this mission that we have a number of programs and services that are available to families as well as to mental health care providers, physical health care providers, and educators. Those resources include programs such as our palliative parenting classes, which are available face-to-face via online courses. We also have an on-demand version of that course that can be taken as a self-guided video course. We have our ketogenic therapy in action program, which right now is being run as a research study and will later this year, 2025, turn into a standalone program for anyone of any age who would like to participate. We also have the CMHRC toolkit for symptom, medication, and mood tracking. It has not only space for historical records of what your diagnoses or your child's diagnoses have been, but it also has the opportunity to make changes, keep current information in there, and we have a version for providers to access as well, which allows them to share their clients' data in real time. So you have a very clear idea of how your clients are doing every single day, whether you see them in your office or not. For this evening, I'd just like to let everyone know, please don't raise your hand for privacy purposes. We do not allow anyone to come off mute and to talk to the group. So if you have any questions throughout the presentation, please put them in the chat. My colleague, Jennifer Sevick, who is CMHRC's clinical director, is taking care of sending out responses. If you don't get a response immediately, please be patient. I'm sure she is either answering someone else's or holding your question until the end for our live Q&A portion. Rounding out the services and programs that we offer at CMHRC are our Wayfinder services. These are very high-touch, personalized support programs that we have devised for families as well as for clinicians, where we provide information and resources around diagnostic support, community advocacy and consultation. We have interdisciplinary groups of mental health and physical health and educator discussion groups in order to promote knowledge and understanding of the way that mood disorders impact when they onset during childhood. As I mentioned, we are a 501c3 nonprofit organization. This event tonight is free of charge, as are all of our monthly webinars and clinical seminars, and the many, many free resources that we have available on our website, cmhrc.org. In order to fulfill our charitable mission, we rely on the generosity of our community. So if you take advantage of our free resources, if you enjoy this seminar tonight, please consider making a gift. We have a campaign running all year long. We're calling it Give 25 in 25. So in 2025, if you have the opportunity to either give a one-time gift of $25, or even better, if you can establish a recurring gift of a monthly $25 donation, that allows us the financial stability to be able to plan new programs and services that will be of service to our community. You can make a donation on our website, cmhrc.org/donate. Now tonight, We are here to talk about what we call the myth of misbehavior. And what we're really going to be doing is examining how to differentiate intentional behaviors from involuntary symptoms of mental health challenges in children and teens. There is a distinct difference between behaviors that children, neurotypical children and non-neurotypical children engage in throughout their childhood versus ones that are actually indicators of more severe mental health challenges or mental illnesses. And yes, I'm going to warn you, we are going to focus this talk tonight on mood disorders such as bipolar disorder and others because that is our area of expertise. And as an organization, we focus on mood disorders that emerge in childhood. But that is not the only place where this information is applicable. And so we are going to use examples from mood disorders throughout our talk, but please feel free to extrapolate that to any co-occurring disorders that the children that you work with or live with may have. So I'm going to start with the sort of big question, which is why do we call this seminar the myth of misbehavior? And that really comes down to the fact that we hear really all of the time from parents and teachers and therapists and other adults who describe children and their behaviors with words like chose, refused, decided. And, so for example, the teacher might say, well, the child decided not to do their work. Or a parent might say, and that was the moment they decided they weren't going to behave anymore. And when we are talking about the behaviors of children and teens, very often what we're actually talking about, especially when those children have a mental health challenge, is that these mood disorders are causing the children to experience involuntary symptoms, and they don't have any control over them. But what we're seeing from the outside is only the action that is associated with that involuntary symptom. And since we're not the ones experiencing it, it can become easy to label those actions that we're viewing as intentional choices. And when we do that, we leave children and teens feeling helpless because they are being essentially called out, punished, or given consequences, which is really just a modern term for punishment, for something that they have no control over. And so accepting this myth that all behaviors, that all misbehaviors are intentional choices rather than symptoms, essentially harms children and teens, but not only children and teens. It also harms their parents. It harms their mental and physical healthcare providers. It harms their teachers. Because when kids are left feeling blamed and alone and helpless to manage their involuntary symptoms, it doesn't bode well for their prognosis. It means that they are not going to get better, and it means that the actions that you're seeing are not going to improve. And so this dynamic, this acceptance of the idea that behaviors are all choices, leaves parents and other adults feeling frustrated, sometimes unempathetic, and they wind up feeling as though they're at a loss as to what they're supposed to do next. So tonight, we're going to take a deep dive into the difference between chosen behaviors and involuntary symptoms. But first, we want to address the opposite. Excuse me, not the opposite. We want to address the obvious, that there are questions and controversies around the idea of problem behaviors and how to effectively address them. These myths exist in part because of the expectations of parents, of children, of the parenting styles that have historically been advocated for by parents and mental health professionals, pediatricians, teachers, you name it, that revolve around the idea of trying to get the child to behave. Now, the first thing we're going to do tonight is I'm going to say to you that when we as adults talk about wanting children to behave, What we are really talking about is wanting these children to follow instructions or to do what we have told them to do. And what that does is strips that child of their autonomy and strips that child of the opportunity to address and manage long term the symptom that they may be experiencing. There's also a fear in the community that around the idea that if we have a child or a teen who has a mental health challenge, they might become emotionally or behaviorally stuck. And that if we attribute everything to their illness, they will essentially become a personality that revolves around that illness, that their identity will become that they are mentally ill or have a mental illness. And so to round out the understanding of what we're talking about with questions and controversy is these are some things that we have heard, actually heard many times from adults, that good kids do what they're told. And so parents and teachers and providers want to know, how do you know that this isn't malicious intentional behavior? How do you know that the child isn't manipulating you? How are children going to be able to learn boundaries and consequences? They have to, because they have to grow up and live in the real world. A lot of times providers will say things like the parent needs parenting classes to learn how to better discipline, control, set limits for their child. And we also, again, want to avoid the idea that parents have that their children might wind up using this diagnosis as an identity and as a crutch. So there is very real concern behind these questions and comments. You know, how is a child who's obviously having significant trouble functioning going to become a responsible adult? Maybe they're having destructive rages. Maybe they curse and use profanity when they are in distress. Maybe there is school refusal. A lot of parents and providers and teachers are afraid. They are afraid for their child's future. Sometimes parents will acknowledge that they're also afraid for their own safety due to their children's erratic episodes of irritability and aggression. But these questions essentially arise out of a concern for the child's future. And so we want to acknowledge that we're not vilifying people who ask these questions. We are recognizing what it stems from, a genuine concern. So with that understood at the outset, our learning objectives tonight are to understand that there is a difference between voluntary behaviors and involuntary symptoms, recognize two ways to differentiate behavior from observable symptoms, to understand two important biological and physiological influences on behavior, and to recognize three tools for treating mental health disorders. So to begin, let's first look at the word behavior, what it really means. And so a behavior is the way in which one conducts oneself. Great. What does conduct mean? So conduct is to cause oneself to behave in a particular way and in a particular and especially controlled manner. And that word controlled is really important because as a result, most people think of behaviors as actions that the individual, and in this case, the child or adolescent, is aware of and controls. And so when we assume the child has control, we are also assuming that they are consciously and intentionally responding to their environment in that specific way. We assume the child is capable of controlling and deciding upon a response based on some sort of internal or external stimuli that they've been exposed to. These assumptions encourage us to interpret what we observe from them as being intentional, willful, a chosen act, which are often described as manipulative, defiant, oppositional, or attention-seeking. These interpretations inflame adults. And that's what causes those feelings of frustration, anger, and even fear. But we're positing that there is a different way to understand what we are observing. And when we understand that there's a different way to understand what we're observing, we are then able to find new ways to help that child or teen when they are in a state of dysregulation. So the good news is, yes, there are ways to assist children and adolescents who are living with this dysregulation and these mood disruptions. And the key here is that we first have to recognize that these behaviors, as I've said a couple of times already, and we'll say a few more, are actually symptoms of a mental health disorder or illness, making them beyond the control of the child. Or if they're not symptoms of a mental health disorder, to recognize that there's still communications from the child or the teen that they are in some kind of damaged state, that their well-being is in danger, and that they in fact need help. All behavior is communication. And so now that we've looked at these definitions, let's look at what the word symptom literally means. So symptoms are a manifestation of a disease that is experienced by and apparent to the patient themselves. So a symptom is experienced by the patient. The symptom is what the client experiences. They may or may not, especially if they're children and teens, be able to articulate to you, the provider or the teacher or the adult, what those symptoms are. But whether they articulate them or not, they're experiencing them. A sign, however, is a manifestation of that disease that the physician or therapist or teacher or adult perceives. The sign is observed by another person, right? The sign is objective evidence. It's obtained through observation. It is obtained through detection through medical findings such as laboratory tests, blood work, CAT scans, MRIs, whatever. But we as mental health providers tend to use the term symptom and sign interchangeably because we're not experiencing the symptom. We can only assess based on the signs or what is described to us as a symptom by the person who is experiencing it. So we are going to be talking tonight about signs and symptoms because this is the universal terminology that is used in the field. But please just keep in mind, symptoms are what the child is experiencing. The sign is what we are observing from the outside. So a symptom may be a lack of interest in doing things that the person once found enjoyable. It's a pretty standard depression symptom. But how it is perceived by others as a sign can vary dramatically based on age, based on circumstances, based on the child's previous experience, based on their trust level with the adult. The sign could be that they're withdrawn and aren't engaging. The sign could also be that they are irritable and grouchy. The sign could be that they simply refuse to get their shoes on, leave the house, go where they're being asked to go. Those three signs stem from, in this case, the same symptom. And when we recognize that the behaviors that we're looking at are likely signs of those symptoms that are being experienced, we can then respond to that in a compassionate and empathetic way. Now, when we talk about symptoms like loss of interest in things that one used to find to be enjoyable, we are talking about the symptoms that are listed in the DSM, the Diagnostic and Statistical Manual of Mental Disorders. This photo shows DSM-5, and we are now on DSM-5 revised edition, and the book just keeps getting bigger and bigger. But every disorder that is listed in the DSM has two criteria that it must meet. And those two criteria are, first, that the disturbance is an obstacle to daily living. It has to be sufficiently severe to cause a marked impairment in social, occupational, interpersonal, or intrapersonal functioning. And I want to remind everyone that occupational, in the case of a child or an adolescent, is school. So this means that in order to be diagnosed with anything in the DSM, the person has to be experiencing marked impairment in multiple settings to the degree that they are not able to function effectively. If that's the case, it's likely we're looking at an illness and not a purposeful behavior that is designed to manipulate, attention seek, or be defiant. The second criteria that they all share is, does the disturbance cause subjective distress for the patient or client? Alienating behaviors are likely an involuntary symptom because children want to please, they want to be accepted. And when we look at this from an evolutionary standpoint, it makes perfect sense. In order to survive, children have to be an accepted and protected part of a group. They don't have the capacity to defend themselves and protect themselves independently yet. And so no child wants to be alienated from their group. So behaviors that cause that, we can first look at and say, okay, that is likely to be an involuntary symptom, not an intentional choice. When children do exhibit that kind of behavior, parents also routinely talk about their children and describe them as being absent or not there behind their eyes. When these extreme behaviors are occurring, children and teens actually report later on that they're feeling intense fear, intense isolation, self-doubt, self-hatred as a result of these symptoms that they don't have the ability to control. Children as young as 5 years old actually report these experiences. And I'm going to share with you now just a couple of direct reports from children of different ages who've experienced involuntary symptoms. And this is how they describe them. So Avery at age 5 said, "I look like Avery on the outside, but on the inside, Avery is gone." When we think about this in the context of the difference between a symptom that is experienced by the individual versus a sign that is observed from the outside, this 5-year-old was telling us that the signs were being misinterpreted because on the outside, I look like Avery, but on the inside, Avery is gone. Isaac, aged 11, said, "Whenever I would go into a rage, the person you see now was trapped inside of a cage, inside of a monster who ran around destroying things. I didn't like that old person who held me hostage inside." Again, external perception versus internal experience. And then Chloe, age 17, said, "In the past, shame and self-hatred ruled my life." This was a result not of only from the fact that Chloe didn't feel as though she was capable of controlling her involuntary symptoms, but also because of the responses she got from others in her environment that suggested that they wanted her to control something that she had no control over. Sometimes children will even go so far as to not be able to remember what happens or what's gone on or what they've said or done during moments of dysregulation or intense symptomatic outbreaks. So Dr. Jerome Wakefield, who is a psychologist at NYU School of Medicine and the Psychoanalytic Association of New York, wrote in 2015, "To be a disorder, symptoms must be caused by a dysfunction. Disorder inherently involves both harmful symptoms tracked by severity and dysfunction, and an inferred failure of some psychological mechanism to perform its biological function. Put another way, when a person lives with a mood disorder, what we observe as symptoms of a biological phenomenon and the body's physiological responses disrupt daily functioning and cause subjective distress. And that is what is contained in those two criteria that all DSM diagnoses must meet: an inability to function and subjective distress. And this leads us to just skimming the surface about the flaws in the DSM. This is confusing for clinicians because there really are significant flaws in the DSM model, namely that it very explicitly and intentionally doesn't address not only any biological causes, but any causes at all. The DSM-5 and the 5 revised and the 4 revised and the 4, the DSM in general has been wildly criticized for over-pathologizing normal human behaviors and experiences. It makes normal behavioral responses into medical issues. Another area of concern is the emphasis on medication management without any real understanding as to the biological origins of the symptoms that are being experienced. And it has been argued that the classification system that's used by the DSM needs to be based on brain biology, not signs that are observed from the outside. All of this over-pathologizing of expected human responses and intentionally not addressing any biological root causes and emphasizing medication management leads to a lot of debate about exactly when is it a disorder versus it being some sort of normal human experience. We would argue that when we're looking at that subjective distress and the inability to function across settings, we are getting some insight into the fact that this is a disorder, not a chosen behavior. And when we do that, we can then start to target looking at what is going on physiologically that might be something that we can address objectively that will relieve some of these involuntary symptoms. At the same time, there are certain basic diagnostic parameters that go along with using a DSM diagnosis, and that includes using existing, proven, validated diagnostic assessments, clinical interviews, reviews of historical information, rigorous differential diagnosis, interdisciplinary consultation, and collaborative team planning. But on a more fundamental level than this, parents, teachers, coaches, babysitters, nannies, mental health care providers, physical health care providers, we can always look back to those two most basic criteria and its symptoms. Does it obstruct normal daily functioning? And does it cause subjective distress? Because if both of these things are happening, then you have a symptom, not a behavior. So you may be asking yourself why we keep harping on this and when I'm going to move on from talking about it. But this is really central. And it is really important because it is one of the things that blocks us as a field from diagnosing mental health disorders in children when they present. Because we look at childhood as a time where kids are supposed to be learning how to behave. And so when there's behavioral disruption, it is very easy for us to say, well, this child just needs to learn how to behave. But that is not what is necessary. A symptom is an obstacle to normal daily functioning. A symptom is causing that child's subjective distress. And so we need to be able to recognize the symptom for what it is as early as possible rather than dismiss them as purposeful behaviors. Early identification and treatment help us reach better outcomes. And so this is a quote from Marco Colizzi, from the International Journal of Mental Health Systems in 2020. He said, promotion, prevention, and early intervention strategies may produce the greatest impact on people's health and well-being. Screening strategies and early detection interventions may allow for more effective healthcare pathways by taking action long before health problems worsen or by preventing their onset. In short, early diagnosis followed by early intervention with effective and targeted treatments is the best tool we have to creating long-term positive outcomes throughout the lifespan. As clinicians, it's our job to effectively identify symptoms of mental illness, to be able to distinguish them from normal human behaviors, and the consistent use of a rigorous differential diagnosis process is essential to being able to determine the difference, especially when it comes to children and teens. And so the differential diagnosis process needs to include solid practices, learned skills, validated proven assessments, and tools that help us developmentally differentiate developmentally appropriate and expected behaviors from serious mental illness symptoms. In order to do this, we have to keep up with current research, which guides us in which targeted interventions and treatments we can use and have a high degree of confidence that they'll be effective. When we recognize symptoms as symptoms and not as behavioral problems, we can turn our attention to then understanding the underlying biological influences and the physiological structures that are involved. So, what exactly are some of those structures involved in the symptom presentation when we're talking about mood disorders in general, bipolar disorder specifically, and its specific phenotype known as FOH? And so to answer this, we're going to have to turn just a little bit to the limbic system. Now, we talked extensively about the limbic system last fall in our two-part seminar series on the limbic system. It was called the limbic system dysregulation and, the limbic system fight, flight, freeze, dysregulation, and de-escalation, where we spent 2 sessions talking in detail about the limbic system and how our knowledge of it can help us provide kids and teens with tools that are targeted to help them be able to manage their dysregulation better. Today, we're going to do a very brief skim of that. If you're interested in seeing that whole series on the limbic system, you can find it on our YouTube channel. Okay, the amygdala, the hypothalamus, and the hippocampus are 3 structures in the limbic system that are involved with regulating the release of the neurotransmitters that communicate with other parts of the brain and body. And so the limbic system plays a really significant role in coordinating how the brain and body respond to both internal as well as external stimuli, and the activation of the fight, flight, freeze response. So examples of biological processes that the limbic system influences include temperature regulation, our circadian rhythms, which include our sleep-wake cycles, our appetite, when it increases, when it decreases, and interpretation of auditory, tactile, and visual processing. So when there is a dysregulation in the limbic system or a dysfunction in some part of the system's processes playing out, there are observable biological symptoms that can be observed. Symptoms that indicate a dysregulation in the limbic system include all of the following, which you can see are represented with symptoms related to sleep and appetite disruptions, irritability and aggression, nightmares, anxiety, fear, inattention, hyperfocus, tantrums. So now that we have this list up, I'm now going to pull up a list of common symptoms of mood disorders and bipolar disorder in children and teens. And as you can see, it's the same list. They're literally identical. This means that there are biological factors that are happening possibly in the limbic system that are the same exact signs and symptoms of mood disorders and bipolar disorder. Now, there are a lot of professionals out there who will say things like, but these things happen to a lot of kids who don't live with mental illness. And sure, that's true to some degree, which is why it's important not to jump to conclusions and to pathologize developmentally expected behaviors. But we can find clarity in determining if these issues present are developmentally expected or not by going back to the DSM's 2 universal criteria. Does it cause subjective distress? And is it an obstacle to daily living? This helps inform whether we are looking at a symptom or a behavior. Now, combine that differentiation with an understanding that the limbic system functions and can disrupt its functioning and create biological root causes to the symptoms and signs that we're observing. This can happen in depression, in mania, in anxiety disorders, in ADHD, in autism, in PTSD. And when we keep this in mind, it can change our understanding of the behaviors that we observe. And we can see that an inability to sleep at night isn't a willful refusal to follow instructions. It could be that the child is experiencing a disruption in their circadian rhythms and sleep-wake cycles. We can then see that a defensive or reactive aggressive response to doing homework might not be a child choosing to be oppositional, but it might be a misfiring of their fight, flight, freeze response where they are experiencing that homework as overwhelming and an insurmountable task where they're being set up to fail. It could be that they are acting out in music class, gym class, recess, at lunchtime, and that isn't a behavior, that's a decision to be disruptive or to get attention or to avoid their schoolwork. It could be that there's a disruption in their auditory, tactile, olfactory, or visual stimuli processing centers in their brain. And that is a symptom, not a choice. But misunderstanding or underestimating the influence of these biological processes on symptom presentation can actually lead to misdiagnosis. We see this all of the time in kids who are diagnosed with ODD, oppositional defiant disorder, who don't have oppositional defiant disorder. They are trying desperately to communicate with their adults that they need help, that they can't manage something in their environment. And so the only way that they can think to cope is to reject and to oppose and to defy what's being asked of them because they can't do it. And so we see this misdiagnosis all of the time. We do have on our YouTube channel a seminar for clinicians to view called the DSM, and it's all on misdiagnosis and why and how that happens and what we can do as providers to correct it. Next month, in March, on the 19th, we will be doing a clinical seminar specifically on bipolar disorder and differentiating behaviors versus symptoms and knowing how to identify bipolar disorder in children and teens. So if you're interested, please join us for that free seminar. Okay. A second important biological and physiological influence on the brain stems from the simple fact that the human brain is one of the most energy demanding, is the most energy demanding organ in the entire body. The limbic system's role in regulation and coordination of the brain and body utilizes synaptic activity that requires more energy than other parts of the brain even. And so, according to Harvard Medical School, the brain uses over half of all of the energy in the body. In recent years, researchers around the world have actually begun to think of unipolar depression and bipolar depression as a mitochondrial disease or an energy disorder rather than a psychiatric condition. In fact, there's an organization dedicated to promoting research in this area. It's called Metabolic Mind. You can find them online at metabolicmind.org. And they refer to bipolar disorder as an energy dysfunction. So it would make sense if we are willing to think about bipolar disorder as an energy dysfunction, that when someone is experiencing a depressive episode, they do not have enough energy. And that when they are experiencing a manic episode, they have, in fact, too much energy, right? That they are experiencing the medical and biological impact of energy regulation disruptions, not a psychiatric condition. This is especially true of bipolar disorder and of the phenotype that I talked about earlier, FOH, or also known as fear of harm, which is what FOH stands for, or TSDD, thermoregulatory sleep dysregulation disorder, because many of its symptoms are caused by the biological dysregulation of temperature disruptions. Temperature and body temperature is also something that is controlled by the limbic system. Now, as I just mentioned, research is ongoing in psychiatry right now, all over the world, looking at psychiatric conditions as biological conditions related to energy. And so Metabolic Mind, as I mentioned, is a nonprofit. Its mission statement on its website is we're a nonprofit transforming the study and treatment of mental disorders by exploring the connection between metabolism and brain health. They have some wonderful podcasts. They also have a great YouTube channel. We highly recommend, if you're interested in learning more about this, that you reach out to their resources to learn more, because there's really tremendous amount of wonderful work that is going on in this area right now and having a tremendous impact. In the fall of 2023, we did a clinical seminar with Dr. Brett Scher, who is the medical director of Metabolic Mind. He is a cardiologist, and we got into an in-depth conversation on the use of metabolic therapies to treat psychiatric disorders such as bipolar. You can find that clinical seminar on our YouTube channel at the Keto Diet and Mental Health Part 2, the science and impact of metabolic therapies on mental illness. We also did a webinar with Jan Ellison Bazuki and her son Matt. Her son Matt has bipolar disorder and has been successfully in treatment with ketogenic therapy. And that is also found on our YouTube channel. Keto Diet Mental Health Part 1, could the solution to the mental health crisis be in our refrigerators? We were so inspired by our work with Jan and Matt and with Metabolic Mind that we launched in mid-2024 our own research study into ketogenic therapy, which is ongoing. And this is where our program, Ketogenic Therapy in Action, stems from. And as I said, we will be launching that later this year to anyone of any age with any diagnosis who wishes to treat it through the use of food, diet, and metabolic therapies. Okay, so we're going to pause here to address another myth or misconception that is echoed in the comments that we hear so often from parents and caregivers and teachers and therapists. and other authority figures. That even with the diagnosis, it doesn't seem responsible to reinforce the idea that it is okay to use mental illness as an excuse. Parents share this belief that the real world doesn't care if a person has bipolar disorder or what is causing their symptoms. The consequences, if consequences and punishments are not given in childhood and in adolescence, then how is the child or teen going to learn how to stop these behaviors? When we really understand and accept the reality that mental illness has biological causes, then we flip the whole mental health model on its head. And we acknowledge that symptoms are not purposeful behaviors, but rather the result of a medical condition, which isn't different from other medical conditions such as asthma, diabetes, or epilepsy. And just as punishment isn't going to stop an asthma attack, you're not going to be able to get someone to stop having low blood sugar by giving them a consequence. You're not going to be able to stop a seizure by withholding a sticker on a reward chart. It's not going to stop the symptoms of mental illness from occurring. And those triggers, when they are rooted in brain chemistry and physiology, are never going to respond to punishment. In the case of mood disorders, punishment can actually propel that person into further crisis because they are not having their needs met, they are not having their medical condition treated effectively, and they're being sent the message that they are the problem when they know the problem is the symptoms that they're having difficulty managing. So the same can actually be said of rewards. Rewards aren't going to stop an asthma attack, low blood sugar, or a seizure either. We know that these are involuntary things, and trying to say, well, if you don't have an asthma attack during soccer practice, we can go get ice cream, isn't something that any reasonable person would say. And so when we try to use a reward system to abolish involuntary symptoms, what we're doing is we're setting up that child or teen to feel helpless, to feel hopeless, and it exacerbates all of the symptoms of their mood disorder that they're experiencing to begin with. Bargaining also doesn't work. Pairing a desired outcome with an impossible task, like promising and then delivering not to have an asthma attack or a low blood sugar or a seizure, that just doesn't work either. And so we advocate for something that, I'll be honest, we get a lot of pushback on, which is stop with the bargaining. Don't create if-then scenarios that children have to follow and deliver upon. Give them the reward, if there's going to be one, no matter what. After you have your blood drawn, we are going to get ice cream. No ifs, no when, no conditional language. And if the child goes to the lab and kicks and screams and cries and won't let the phlebotomist draw their blood, they still get to go out and have ice cream because that was what was promised. And that is how we build trust, acceptance, and understanding in a bi-directional way with that child. So remember, if punishment, rewards, or bargaining work and behaviors resolve without other interventions, then the behavior likely wasn't related to a mood disorder or another mental illness. But if it doesn't go away, then you're left with the reality that you can't punish, reward, or bargain away biology. And so if that's what's happening, it is likely that you are dealing with a biological or physiological underlying cause of a symptom that is involuntary. Now, we say this over and over and over again. Those of you who are new to our work should know it's an incredibly important thing that we work hard to communicate and make as clear as possible, that a dysregulated child or teen who is not able to function in their environment is experiencing a medical crisis, not a behavioral crisis, a medical crisis. We are not going to require that a child with asthma earn the right to their inhaler. We don't expect a child with diabetes who's experiencing low blood sugar to resolve that problem by using coping skills. We're not going to suspend a student who hit their teacher while they were having a seizure. We fully recognize that in these cases, what they have experienced is an involuntary medical crisis and are in need of immediate attention to address their immediate need. So now we need to do that when it comes to mental health symptoms as well. So how do we do that? How do we treat these disorders in a way that acknowledges the biological foundation and the need to move away from punishments and rewards? It is an excellent question. There are three primary tools that patients with serious mental illnesses and their parents and caregivers need to use in order to achieve and maintain stability: medication, therapy, and lifestyle interventions. We call this the three-legged stool of treatment because just like a three-legged stool, if you remove one of these, one leg from the stool, it's going to fall over. All three pillars are necessary for successful treatment. And successful treatment can fall apart if one of these pieces is denied or removed. Now, I do want to acknowledge right off the bat that there are a lot of people who don't agree with the idea of giving kids medications. Not everybody is comfortable with this, and ultimately what medications, how much, that is a decision that is made by an individual family along with their individual provider. We are not here to tell you what medications to take. However, we will say that for most people who have biologically based mental illnesses with physiologically driven symptoms, they need medication, and it's a game changer. No one should be forced to take medications they don't want to take. And they should have a very clear and unbiased source of information in order to learn about what those medications may and may not do to help them and to benefit them, what they may and may not do in terms of side effects that could be problematic for them. And they need to be able to make a truly informed decision. But with that in mind, there are some very legitimate objections to medications. We hear this from providers and parents and adult patients all of the time. One is that medications have too many side effects and can be potentially harmful. The other is that they wind up being a crutch that will prevent the child from learning how to cope, and that it doesn't solve everything. In each of these cases, these concerns have merit. But when we do a cost-benefit analysis here, the risks associated with a careful, attentive, and slow titration of a proven medication may far outweigh the risks associated with not treating the disorder medicinally. So what do we mean by that? Statistics show, and again, we're using bipolar disorder as an example here because this is an area of expertise for us, and we can speak fluently on the topic. Bipolar disorder statistics show that 20 to 60% of the 6 million people with bipolar disorder at some point attempt to end their life. Nearly 20% of those who attempt do in fact die by suicide. There is a 40% lifetime prevalence rate of developing a substance abuse disorder if you have bipolar 1. and a 20% lifetime prevalence rate of developing substance abuse disorders with bipolar 2. Not treating bipolar and other mood disorders when their symptoms emerge has potentially devastating consequences. When we deny treating mood disorders as the legitimate medical conditions that they are, we run the risk of setting people, our clients, our children up for the absolutely most dire of consequences. Becoming aware of these and other statistics is an integral part of a family's decision-making process about whether or not and how to use medication in the treatment of their mood disorder. Now, once medication is being used, it is very important for patients and families to be able to track the effectiveness of the medication, its dose changes, the frequency with which it's taken, the consistency with which it's taken. This is really important because this is the only way that we can know truly whether or not the medication is treating the symptom it was designed to treat. Very often during medication trials, a patient will say, well, it's not having any effect. That may be because it's not having the desired effect, but it is having effects in other areas that may or may not be beneficial. But they report to their provider, well, it's not doing anything. And the provider says, well, let's increase the dose. But if there is an objective measurement of what is happening in terms of symptom presentation in direct connection with the medication changes, you can make medication changes that are smaller. You can ultimately land on a therapeutic dose that is the lowest possible dose to get the job done. And you are able to target specific symptoms with specific medications. This kind of tracking is complex, and it can be difficult without a system in place in order to do it. I mentioned earlier that at CMHRC, we have developed a tool specifically for parents and providers to be able to share this information. It is called the CMHRC Toolkit. You can get information on it on our website. And on it, you can track daily moods, symptom presentation, their intensity and frequency. You can track daily medication compliance, have a long-term record of medication changes and its impacts. You can track the daily weather. You can track all of this stuff and create easy-to-read graphs and summary aggregate scores of symptom presentation. And as I mentioned, this is for use by parents and as well as providers. The parents fill it out. They share their data with their provider through the provider's toolkit account, and the provider is able to see exactly what's going on with their patients during medication changes, during treatment adjustments, during other adjustments that may be going on in the patient's daily life. And as I said, both families and providers can use this. Patients are able to select their provider from a list of participating providers. To become a participating provider, all you have to do is sign up for an account. Providers have one rate. Regardless, we do not upcharge anyone for the number of patients or clients that they refer and have using it. And when you refer your patients to it, you will get they will get a discount for having been referred by you. But this is useful for prescribers as well as for non-prescribers, as well as a tool for parents and teachers to communicate in real time back and forth how that child or teen is doing at school. So if you're interested, you can check that out on our website, cmhrc.org. Under the Programs and Services tab, you'll see the CMHRC Toolkit. Now, on to that next leg of the stool, therapy, which in this process, therapists can still use the CMHRC Toolkit and track everything with their patients. Therapy can include a lot of different things. It's not just psychotherapy. Although psychotherapy is important and highly recommended, It can also involve speech and language therapy, occupational therapy, physical therapy. Um, Different individuals will have different needs, but when we are talking about disorders that have physiological and biological underpinnings, it makes perfect sense that there may be other physical implications that need to be addressed through occupational therapy or physical therapy or speech and language therapy. Um, Whatever skills are being taught during these therapy sessions, we need to remember as professionals that a child who is experiencing a fight, flight, freeze response will not be able to access what they are being taught in terms of skill implementation. And so there may be a disconnect between what they are capable of comprehending and what they are capable of implementing in a moment of dysregulation. This is where these other therapies like occupational and physical therapy can be extremely helpful in giving a child a sense of mastery over themselves, even during states of dysregulation. Now, when psychotherapy is engaged, and it can be, many providers and families have seen tremendous success with psychotherapy. Um, but one of the things that we have to do as providers is validate the parents' and the family's experience. We have to listen first. We have to understand what they have already tried before they walked into our office, what worked, what didn't, what their insights are as to why certain treatments may or may not have worked. We have to prove ourselves to be knowledgeable and trustworthy. A lot of us think that because we have a lot of initials and credentials and certifications after our name, that inherently makes us trustworthy. It doesn't. What it does is it makes us qualified to provide treatment to children, teens, and their families who are living with mood disorders. But it doesn't mean that they're going to walk in trusting us. And one of the things that we say is that we have to look at some of the statistics on therapeutic interventions in order to understand why we're not necessarily going to be considered to be trustworthy right off the bat. And the staggering truth is that research estimates that there is a median 10-year delay between when families realize their child needs some kind of psychotherapeutic intervention or psychiatric treatment and when they receive it, when they receive accurate diagnoses and effective treatment plans. And so we know that many children and their parents are shamed and blamed for the behaviors that their child is exhibiting. Behaviors here being the signs, the observable signs of their mental illness. And so when they have experienced many years of being shamed and blamed, it makes them wary of new providers. It is typically going to take a very long time for a family and a child to trust you. And one thing that I always say to folks that I've worked with is this: I can tell you to trust me, but that's really not going to do any good. The only way you're going to trust me is if you experience me as trustworthy, if you experience me over time as being someone who honors your trust. And so in this case, it can take a tremendously long time for a child, especially one whose symptoms include an aggravated and misfiring fight, flight, freeze response. It's going to take much longer to build the rapport necessary to get traditional psychotherapeutic work done. And we focus on the person-centered treatment that allows our clients to experience unconditional positive regard from us first and foremost. We did a clinical seminar last year on clinical instincts and how they can guide us and improve our clinical practice. That is also on our YouTube channel. You may want to go back and look at that. We talk in great detail about this rapport building phase. Now, once rapport building is successful and you have your client's trust, at this point, it is still important to remember that traditional cognitive behavioral models often don't work. They especially don't work when kids are dysregulated, when they are not stable. The frontal lobe and the executive functioning skills necessary to access the cognitions are often blocked by the dysregulation in the limbic system. So their inability to access what you've taught them when they are in the moment of dysregulation is actually a biological function of the biological and medical crisis that they're experiencing in those periods of dysregulation. Symptom remission is required before we can teach any coping skills. And I know this sounds controversial to many providers who have been trained in modalities that are formulaic, that say that there is a specific order to skills and tools and techniques that we're supposed to teach to our clients. But the truth is that you can't get anybody to implement any of that when they are actively symptomatic. You're not going to get them to learn it when they are actively symptomatic. And so while they may eventually become effective treatments, they do not start out as them. We have to make sure the client is capable of accessing the skills that we are teaching them before they can be expected to routinely implement them in a crisis situation. And that's hard for us to remember, especially when we want to be able to document progress. And sometimes the documentation of progress is simply that our clients shared how they are doing with us in an honest way. To achieve this, we, as I mentioned, highly recommend a person-centered approach. Here we're talking about the Rogerian theories of Carl Rogers, that when a child or adolescent first comes into therapy and they have a mood disorder, that the focus really needs to be on an acknowledgement of their struggles. They need to feel validated, that there is an illness with involuntary symptoms, that we're not equating their symptoms with their value as an individual. And that what we're doing at the beginning while we are rapport building and developing trust is providing education to the child, the teen, to their family, their caregivers about what the illness is. And we are, as professionals, providing resources. It is these experiences of being validated, of being understood, of being given information, not talked down to, and being given resources outside of just therapy that develop those feelings of trust and safety. Being a safe, welcoming, warm, and accepting person and place, and providing that unconditional positive regard will make the microcosm of the therapeutic relationship the tool for change. The third pillar or leg of that three-legged stool are lifestyle interventions. And so what are they? This is everything from sleep hygiene to diet and food plans, exercise routines, meditation, successful social interactions, intellectual opportunities, cooling strategies, and the list goes on and on. All of these things play an integral role in achieving and maintaining a high quality of life. There are absolutely going to be certain through lines and consistencies from person to person in terms of what lifestyle interventions are going to be most beneficial. For example, sleep hygiene. Reducing blue light exposure throughout the day, not just after sunset, establishing a clear and firm bedtime routine. That includes having a set time to go to bed, a set time to wake up every day. These things universally will promote the alignment of the circadian rhythms with the sleep-wake cycle to the cycle of sunlight and hours of light and dark throughout the day. Sleep is almost universally pointed to as something that can be addressed to help manage symptoms of almost any mental health disorder. But there are also going to be things that are specific to an individual, which you will be able to learn. We have on our website a book that we've created on lifestyle interventions, specifically cooling strategies and circadian rhythms for sleep and temperature regulation. You can order a digital copy of that book on our website, or you can buy a physical copy from Amazon. You can look at that on our website under programs and services. It has the CMHRC bookshop, and the links are all there, where we go through with you specifically how do you create a plan for your client, for yourself, for your child that optimizes temperature regulation strategies as well as sleep regulation strategies to maximize their positive impact on mood, mental health, and mental illness symptoms. This book has templates in it that can be used so you can experiment and find exactly the system that works best for you. These lifestyle interventions should be personalized in order to maximize their effectiveness. The most important thing they do, though, is they will provide structure and support for long-term symptom management. We would be remiss if, while we're talking about all these three different treatment tools that we have, if we didn't mention that the best tool we have is to let go of the idea that there is a fix, end, or cure to the illness. And I do not say this to be negative. I do not say this to be pessimistic. I do not say this to be judgmental. Research is ongoing and making tremendous strides. But for now, there is no cure for any mood disorder that we know of. There are, however, incredibly effective management interventions. There are strategies, techniques, tools that we can use in order to be able to provide effective treatment. The person is not the sum of their symptoms or illnesses, and their experience does not need to be erased in order for them to experience improvement. In the palliative parenting class that we teach, again, you can do a face-to-face class with live instructors and classmates, or we have an on-demand self-guided video course that can be used in order to take the palliative parenting course. We focus on the fact that the best thing that we have in terms of managing symptoms is making sure that we are improving quality of life. And quality of life improvements stem first and foremost from understanding that we are learning how to manage long-term a chronic medical condition, just the way we would have to manage long-term asthma or diabetes or epilepsy. And this is not a criticism of the client or patient or individual. It is the tools that they need in order to be able to experience long-term stability. Now, oftentimes, look, this is a radical paradigm shift away from fixing. Parents very often want their child to be cured, and we understand that is a reasonable, understandable response. But as providers, it is our job to help families face the reality that at this point in time, there are no cures. And that when we approach parenting a child or teen with a mental illness, and we look at it from the standpoint of improving quality of life, we are actually going to be able to have a much more positive short and long-term effect on symptom management, but also on the relationship. And so again, This is what we teach in our palliative parenting class. It is a framework for parents whose children live with mental health conditions. Now, I'll say that this was created out of necessity. We recognized that through collaboration with parents of children who live with mental health conditions, through collaboration with adults who experienced mental health conditions as children, and with mental health professionals as well, we were able to come up with a parenting strategy and approach that doesn't shame or blame the parent, doesn't shame or blame the child, and focuses intently on improving quality of life. And the reason it's called palliative parenting is because palliate means to ease symptoms or to lessen intensity, regardless of what the illness is. We tend to think of palliative as focusing on end of life, but it's not. And palliative parenting means parenting with the primary intention to improve quality of life through easing symptoms. And it is a process for navigating daily living, for navigating decisions, and for developing within the child or teen the capacity for self-care. Now, to be blunt, most of the parenting paradigms and popular parenting strategies out there, a lot of them work for kids who are neurotypical, but almost none of them work for kids who are non-neurotypical. The palliative parenting model works for kids who have neurodivergence, and it also works for neurotypical children as well. So this approach that we teach is anchored in an acceptance, respect, and community approach that allows parents, teachers, providers, caregivers, babysitters, nannies, grandparents, you name it, anyone who is in a role of giving care to a child. It gives them a completely different framework from which to work. And it means changing the adult's perspective, not the child's perspective. Just as in therapy, we use the microcosm of the therapeutic relationship to teach skills, to teach tools, to encourage positive change. In palliative parenting, we use the parent-child relationship and the bi-directional nature of it as the tool to create positive change for the child. We talk in palliative parenting that the change starts within the parent's mind, within the parent's thoughts, and within the parent's feelings. And that we recognize parents as the ultimate expert in their child. And the term we use to talk about palliative parents is that they become parent professionals who are the experts in their child, in their child's symptoms, in their child's needs, and in their child's capacity to manage and to learn new things about how to take care of themselves long term. When it comes to seeking a provider, families, and we've worked with countless ones who have shared with us that they're looking for providers who understand mood disorders in children and teens, that have some sort of specialty, have some certification, have completed some process like our professional discussion groups that focus for 6 months on how to recognize and treat bipolar disorder in children. Families want that. They want to know that their provider truly understands mood disorders and aren't going to brush them off and describe them as behavioral challenges only. To go with that is that families want providers who recognize that behaviors and symptoms are not the same thing. Families want providers who are willing to partner with them, and they want providers who are willing to advocate for their children. Together, when we do this, we are able to become the providers that the families who seek out our services need. And through that, we are able to provide education, we're able to provide support, we're able to provide advocacy, and we're able to set that family up and that child up for success today and throughout the lifespan. If you'd like to learn more about bipolar disorder in children, as I said, next month we are going to have a clinical seminar free of charge on identifying the symptoms of bipolar disorder in childhood and adolescence. So you can join us then for a overview of bipolar disorder in kids ages 5 to 15. If you like that, enjoy that, and would like to look at it more, as I said, we have professional discussion groups that meet from April through October. They meet once per month for 90 minutes, and that is an in-depth deep dive in an interdisciplinary team of providers where we will give you lots more in-depth information, resources, and supports in order to be able to treat bipolar disorder in your clinical practice. You can find out more information about that on our website, cmhrc.org, through the free resources tab under clinical seminars and under the programs and services tab under professional discussion groups. This slide includes a bibliography where some of the information in today's session came from. This slide, as well as this slide, as you can see, we drew from many sources. And that is the end of the presentation for today. If you would like to participate in our live Q&A, please stick around. This is, however, where the recording will end because we reserve the live Q&A for people to ask questions that may be private in nature. And so if you are watching this on YouTube at a later date, please consider attending one of our sessions live so that you can hear the questions and answers that are provided in the live Q&A. As many of you have already asked, certificates of completion are provided only for those who attend the live event, and you can reach out in the email that is sent to you tomorrow from Zoom that will have a link to make a request. The certificates cost $5. We keep this price very low, but it is an important piece of making sure that we can provide services to the general public for free.